Welcome to the Mental Health Moment. My name is Michael Colburn. I'm an adolescent medicine specialist here in Iowa, practicing in Iowa City. We would like to talk to you a little bit today about mental health, so I will let my co-hosts introduce themselves.
Hi, I'm Dr. Amy Shriver. I'm a general pediatrician working in Iowa and also part of the Iowa AAP. I practice in Des Moines. Dr. Colburn and I are getting together to support other pediatricians across the state and working with children who are coming in with some mental health concerns. I'm going to interview Dr. Colburn, and is it okay if I call you Mike? Is that okay?
You can
Um,
call me Mike.
so, so Mike, um, in Iowa during COVID, we've seen a lot of kids who have isolated, as they were told. They were told to not go to school. They were told to stay home. They were told to stay away from other kids and stay in their homes. They lost their sports, they lost their activities, and pretty much were just kind of stuck at home. Some of them stuck on their phones. And we saw that that wasn't really great for kids. Can you talk about what you've been seeing?
So I've been seeing a similar thing. So being an adolescent mental health specialist, I work a lot with teenagers and young adults. And that social isolation, even though when we think of teenagers, they're connected through their phone and having relationships, kind of this is the critical moments where they're building those relationship skills on how to navigate different personalities, friendships, terminating friendships, relationships, dating, all sorts of stuff. And it was kind of all placed on hold. And with being reintroduced back into kind of like society again, there's been a little bit of a stunting effect on how these kids are doing and how they feel. I don't know about you, but we've kind of talked about in the past that I've been seeing a lot of a mixed bag of kind of anxiety, depression, worries, stressors about several things being like, how am I going to perform? How did last year's school performance affect my future? What about my friends? What about my family safety? What about the vaccine? A lot of worries and kind of thoughts of self doubt have been going through a lot of teenagers' minds.
Yeah, I've been seeing the same thing. And really in starting in October, November of 2020 and definitely through the spring of 2021, I had kids and teenagers coming in with the chief complaint of not sleeping very well or appetite disturbance or school trouble or just coming in for their, well adolescent visit. And in almost all cases, there was a link to their mental health and well-being, and some of them realized it and some of them needed to acknowledge it a little bit. Definitely that social piece of kids lives was missing, and that is such a crucial part to children's and adolescents social development. Yeah, kids were really hurting, and that was, I think, a tidal wave for me. I hadn't seen so many kids coming in all at once with the same concerns, and as a general pediatrician, I felt like, hey, I need to step up my game here. I need to be prepared. I need to know what to do. I need to make sure I'm screening as I should. I need to make sure that I have the proper resources for the kids and that I'm following the appropriate follow up for them to keep them safe. So let's talk about your recommendations for screening. So, if let's say this is a 13-year-old male who comes in and he fills out a, I don't know, does he fill out forms for you or what is he doing for you if he's coming in just for a well adolescent visit?
So I think that a lot of us try to utilize like what are good questions, what are things we need to know, how do we assess their social health, their mental health, their well-being, assess for risk factors, kind of in a rapid succession because we have limited time with our adolescents during things like well visits and sports exams, right? So when we look at what the academy recommends as good practice is using like a standard validated tool that can screen for mental health such as depression starting at ages 12 and doing it at a frequency of least annually. When you look at the tools that are available, a lot of times when we partner with our adult providers, something that's called a Patient Health Questionnaire 9 or a PHQ 9 is something that might be already part of our EMR or welcome questions or ways that we can go about asking them. When you use those tools, it's basically an operationalized city tax. And sometimes they ask one of the first two questions, which would be assessing anhedonia or lack of interest. And sometimes it might be beneficial to actually ask all the questions for adolescents to get a broader sense of how they feel, knowing that sometimes they might not identify a mood discrepancy, but they might have negative self worth, sleep disturbance, these other things that go into kind of depression. When you use adult validated tools, they don't include words like irritability, which notoriously irritability can present as depression in adolescents and young adults. So it's kind of good to look at what are potentially other tools. A good validated tool starting at age 11 and going through 17 is something that's called the Patient Health Questionnaire modified for adolescents. So it's a PHQA. In addition to asking those questions to assess their mood, it also assesses suicidality independently with a past history of suicide or major thoughts over the past month. Evidence shows that sometimes suicidality in teenagers run without a diagnosis of depression, and being the second leading cause of death in this age, it's good to assess those questions. So using those kind of tools can help start the process, the conversation, and kind of guide us a little bit on further gathering information. So that's what we do in our clinic.
So I use the PHQ-9 too. I use it at all the visits starting at 12 and up for well child visits, but I also will pull it out if a child comes in for something else and they mention that, oh, I don't, I'm not sleeping well, I'm not eating well, I feel bad all the time, and so I'll use that screen at that time too. Um, and speaking of irritability, I feel like that I my teens can really relate to the irritability part, and I haven't used the PHQ-9 for adolescents, so that's a great tip. I sometimes will also pull out some anxiety screens because I know that when you're depressed, you can become irritable, but also anxiety makes you like not you have a low tolerance for nonsense and other people. And so I know I use the GAD-7. I don't know, what screen tools do you like to do during these visits for adolescents for anxiety?
A lot of times when I have people that are coming in for chief complaints or referrals or second opinions, I look at kind of the category of symptoms they're having. And your mind and body is so connected that when pain complaints are present, it's a very good option to also screen for mood concerns. So people are coming in with chronic headaches, chronic abdominal pains, sleep disturbance, school avoidance type things. Those are really good because they won't say in their chief complaint, I'm depressed. I think it's really hard sometimes for a teenager to say things like, I'm depressed, because they don't necessarily know what that means, right? It's a different language for them. And they're living this life that this is who they are. And it's really hard to take depression and separate it from like their identity at times, or feeling like it's a personality trait that they have. So they might, a lot of times when I'm working with teenagers, like say comments that this is just how I am. I used to not be like this, but this is me, right? And it's really important for us to be like, you are you. Depression is a separate entity that we can work towards treating, right? So
That's a
GAD
really
7
good
is a
point. Yeah.
yeah, thanks. GAD-7 is a great tool. So I like to use GAD-7, which is a generalized anxiety disorder, just like what we think GAD is. And it's a 7 questionnaire. It includes that irritability comment. So if your institution is using a PHQ-9 and you're like, shoot, I want to use something different, this is a way to help supplement and look for that irritability component. And then just having more of a dedicated kind of discussion with them about self harm and suicidality can help overall round out that. So I use the GAD-7 a lot when I'm following kids for mental health, when I'm trying to figure out if there's mental health, and sometimes it's part of the well visit, depending on other things they say.
So, when a pediatrician like me would use a tool like the PHQ-9, we get a number at the end, and the number relates to whether the results are mild, moderate, or severe, and that helps us decide, what we need to do immediately and what we should do kind of long term to support the child. So what would you do in each of those categories?
Yeah. So when I look at kind of the overall number, 10 is usually like this number across the board that we have evidence and kind of expert opinion on. If it's 10 or above, there's likely going to be little self resolution without some kind of intervention. There was a really good study that kind of looked at adolescents and using something like the PHQ-9 and seeing that what their scores were, and with close follow up in 6 weeks, how their scores either remained, lessened, or worsened. And when scores were found to be 10 or higher on initial exam, greater than 80% of those persisted or actually were worse. So, kind of self resolution, partnering with parents, and those interventions, which are so strong and great and help bridge the gap to treatment, when their higher levels didn't seem to make as much of an impact long term prognostic. So, kind of 10 both on the GAD and the PHQ is a good threshold. When you look at that on like the translation, a lot of times that's going to be the threshold around where we start talking about moderate symptoms. So moderate and moderately severe and severe symptoms are kind of when I start talking about all treatment options, which includes therapy as well as medication. When they're lower scores, sometimes their depression is really bad. And then they still might, it's good to explore, right? I don't know who filled out the questionnaire. Sometimes parents are sneaky and they fill it out for them. So they're giving us a kind of assessment. Sometimes people are low symptom reporters that are still significantly impacted, where they're pulling away from friends in school, and some of those questions aren't really highlighted on the screener. So using the screener as kind of a way to gauge how where they're at in time and supplementing it with kind of like what things they're noticing. What are the qualitative symptoms that they prioritize are helpful ways to kind of get a more rounded picture of how they're doing, how they're progressing, what kind of next steps there are. So that's kind of how I look at stuff.
Okay. So that number 10 is really helpful because sometimes I get sevens and sometimes I had some 21s. So it's really good to know kind of when to really dig deeper and when to, say, okay, well, I think we're in kind of a milder category here, but let's explore it more. So let's say that this 13-year-old that shows up in your office has a score of like, I don't know, 15. So what is your next step after you get the score?
So when I get the score, the first thing I do is I kind of look at the PHQ-9 or PHQ-A to see what are their symptom flags. You can usually break it down into, in my head, what I think is like two categories. One is kind of their mental health and depressive symptoms, and the other one is kind of the somatic symptoms that go with depression. When I'm seeing issues with mood, anhedonia, negative self worth, suicidality, even if their score is a little bit lower, those things all prompt and support that greater interventions could be beneficial. When I'm seeing things that are more along the lines of sleep, fatigue, concentration issues, I definitely want to explore to make sure that they have good sleep hygiene. It's not uncommon when we use these tools that they might have higher scores when there's a transition point, such as going back to school. They might not overall be worried or stressed or depressed about going to school that's disordered, but they're coming off their summer sleep schedule and therefore they're having issues with it's hard for me to get up in the morning. So kind of I like to look at what the numbers are to give me more of a sense. And then I talk to them about those kind of categories to flesh out a better understanding. When a kid that has like a score of 15 who has depressive type symptoms, what I like to understand is kind of a timing of how long this has been going on. Is this the first time that we've noticed stuff like this? And like you were talking about with anxiety, it's helpful to know if there's like a long standing history of anxiety. Is this kid the kid that's always been worried about stuff, right? And when our worries are uncontrolled, that can lead to kind of negative self worth, which then we start broaching the depression diagnosis. When I get a better understanding of this seems like a solid kind of state for this youth, then I talk about what past things have we done, right? Have we done interventions before? And when no interventions have been done, I then assess kind of where their thought process is, as well as their parents. There's a lot of barriers to mental health that it's good for us as providers to address. And the best way to address it is to figure out what the parents and patients' understanding of certain things and kind of giving them education and guidance.
It's always good to meet the family where they are and to just get kind of more of a background. Sometimes we jump in thinking we know a lot about depression and what we can do, but it's really helpful to really get more insight into what what's going on in their lives and what experiences they have or what thoughts they have, because I think a lot of people have different thoughts about mental health. And so it's great to meet patient and family where they are. So sometimes when we do screens and we have like a moderate score, sometimes there are scores on particular questions around thoughts about suicide. Can you talk more about how pediatricians like me can be better at identifying suicidal ideation and what should we do when patients that have moderate or severe depression are starting to mention those things, or even if they don't identify them on the screener that we use, how should we pay attention to that?
So, first, great job. If a youth tells you that they're having these thoughts of escape or suicidality, they trust you to a level that they know that you can partner with them and they're reaching out kind of to partner with you for support. So, great job at just starting right there. Once that kind of conversation comes up, I like to talk to kids about, and usually my standard of practice, regardless of if they check that box or not, is when I'm assessing their overall mood and well being, like part of a well visit, getting them at their language. So, would they say most of their days are good days? Most of their days are bad days. When they have bad days, do they seem to cluster or the next day could be just as good? When you're having bad days, do you have people in your life that you can kind of turn to and talk to about things? Have you ever had any thoughts about hurting yourself? And I use hurting yourself because there's a lot of ways that kids can inflict pain upon themselves to kind of process their emotions, right? Kids don't always just cut, they can scratch, they can burn, they can hit themselves, they can hit the wall, all sorts of things. So, understanding if there's ways that they're trying to deal with their mental frustration in ways that hurt their body is super helpful. And then I ask them if they ever hurt themselves on purpose. So, I partner the thoughts with the actual actions and then go from there. So when we're having that conversation, a lot of times thoughts about hurting themselves pop up. And in that conversation or the actions, figuring out if there's ever been an intent to kill themselves behind it is helpful. When there is an intent, right, then we go into what are our safety plans. And even when there's not an intent, it's still good to go into what are our safety plans to kind of help protect this kid and create an environment that is the safest it can be. I like to think of adolescence as benefiting from bubble wrap, right? The more we're kind of able to put bubble wrap around stuff or wrap stuff up really tightly, the more barriers we're able to put in the place of things, the more they have time to reflect, right? Even when kids are having suicidal ideation, or even when kids have absolutely no suicidal ideation, they can still attempt suicide, right? So it's a helpful risk factor, but it's not a one and done. A lot of times, adolescent suicide attempts are impulsive actions. So, partnering with them to figure out how they start noticing that these thoughts are coming upon them. What are their triggers? What things have worked for them before in the past when these triggers happen? So, how do they self de escalate? Who are their go to people? I think sometimes when we ask that question, we might ask it in a leading way where we might say, hey, if you're having these thoughts, would you talk to mom and dad? And a lot of times our patients want us to be happy. So they would say yes to that answer, even though that might not be what they do. So figuring out who they would actually talk to when they have thoughts that worry them is a good plan. A lot of times it is mom and dad. So by them telling us that, then that solidifies that plan a little bit better. And when they pick friends, right? We're like, oh, we don't want you to talk to your friends, but that's what they're going to do. So follow the pathway from friends to someone that can keep them safe. So figuring out if your friend is worried about you, who would your friend talk to? Because it's great that they have their friend. Their friend is probably going to distract them and get them out of that headspace most of the time. Friends are very insightful. So if friends are realizing that things aren't going well, we just need to make sure friend has a plan, right? A lot of
Right.
times friends have access to parents. So they can text and call and let that person's mom or dad know. Sometimes they don't. And if they don't, well, let's give access to them, right? We're all adults. And if you ever have gone to the NCE, you have to fill out your emergency contact information. For me, it's my husband, right? So we just need to make sure that this kid, who is their emergency contact friend, has the information to get a hold of their other emergency contact mom, right? Kids can sometimes super worry when you ask them to share numbers like parents. So giving them scripting usually helps them the most. So you're not giving this kid your number because I'm worried that you're going to attempt suicide. You're giving this kid your mom's number because you never know when you're on the side of the road and you got knocked unconscious and your friend's super smart and they called 911. And as the ambulance comes to take you away, your friend's like, wait, I should probably tell your mom that you're
Tell
not
your
coming
mom.
home for dinner,
Yeah.
right? So
I mean,
giving them
that
like scripts help.
that exact thing has happened to my patients before. You mentioned that adolescents sometimes, in the depths of despair, will have impulsive moments and may do things to harm themselves. And sometimes also because they're so connected via their phones, they might reach out to a friend and say, I did something, oh, I did something. And then that friend is a great person to not only like try to help their friend, but also to notify people that are right there that can maybe, intervene and do something. So I think that um, understanding how teens work and understanding how they stay connected and who they would call if something happened, and then making sure that those connections to the safe person are there. And then I think there's a lot of I don't know, just like when someone tells you as a provider that they're suicidal, you have a lot of feels about that, and you might have tendencies to try and say something or something else to talk about that. What do you say to your teens if they say that they've had suicidal thoughts recently?
So a lot of times when I'm bringing up this conversation, like during the first times I'm getting to know people or potentially during well visits, I talk about how people can have a lot of like thoughts about self harm. And sometimes those thoughts can be like, I just wish I wasn't here. Those thoughts can shift to be like, if I was dead, I wouldn't have to deal with this, to people thinking about ways that they might hurt themselves, to people then starting to plan and act on ways they might hurt themselves. So knowing that suicidality is a spectrum is super helpful. And I think when you're talking to your patients about this concept and they share this information for you, it helps you be able to explore where they are. And like I said, right, impulse is high. So there's indicators and risk factors, but nothing's said and done. So kids that are even having thoughts of escape where they just want to socially isolate and they just wish they didn't have to do anything anymore, they can still act upon those without having a plan. But if you get a sense of where they're at, it can kind of further help guide your discussion with them, further help kind of link into greater buy-in sometimes for mental health interventions, right? Validating and thanking them for sharing that, right? Your feelings are valid. Your actions we want to change and work upon, right? It is hard to take away tools from a kid that uses self harm as a coping mechanism if we don't give them other tools. So, acknowledging that they have learned ways to deal with things, but there's good ways that we can explore to help them decrease these kind of injuries to their body, kind of help strengthen that linkage, right? We don't want to just spray them with a water bottle and say, no, never do that again, because that's an unrealistic expectation.
I think that is such a great piece of advice that can be applied all across parenthood. Oftentimes, even in toddlerhood, parents are like, "Don't do that, don't do that, don't do that." Well, they're doing it for a reason. So if you want them to not do that, you have to maybe help teach them an alternative way of expressing themselves or dealing with emotion or communicating. And so even in toddlerhood, parents tend to get in that trap of don't know. Whereas really what we want them to do is say, instead of doing this, we could do this, and that would help you more. And this is why. And so even in adolescence, that continues to be true, right? Where we want to say, I see why you're doing this, and thank you for telling me why, and let's see if we can help you deal with the same concerns in a different way, and so that you can continue to improve and feel better. I just feel like as a provider, there's so many feels that go into taking care of someone who's feeling so um, hopeless and sad, and so it's good for us to feel prepared because I think that's the number one thing that will help us help them the best is if we're able to be confident going in saying I know even if the score is the highest score I've ever seen. I know what I need to say to assess whether they're safe or not. I need to know how to keep them safe with a safety plan. I need to know who their connections are and how to make sure information travels to a safe place if something happens. And then for us, it's also good to know about treatment options for kids who have moderate or severe depression. So, what are your favorite treatment options for kids who have scores that are higher than 10?
Yeah. So I think, and even with your kids that have scores that are lower than 10, right? Having active monitoring where they have close follow up with you, that they have already established a connection, have felt comfortable sharing this information with you. When those kids fail to progress and you're noticing that there's impairment in their realms, either school productivity, work performance, impairment in social interactions, both at home and with friends, those impaired issues could still warrant further escalation of your treatment. So I like the score as I usually tend to use the score more as a vital sign that helps me monitor because I have their baseline and now I can see how things go. It's not validated to do it that way, but a lot of people in psychiatry realms will kind of follow these scores and see the ebb and flow, and as long as you're partnering it with a conversation with your patient, it kind of helps guide where their trajectory is. So using it as like a nice way to get your CTAPs or your operationalize, symptoms of depression, but then adding your qualitative assessment and then monitoring over time helps you figure out what kind of steps to do. When I have a kid that's moderate, severe right off the bat, that's having passive thoughts of SI, that's having disordered in their relationships, their school, social isolation, pulling away. When we look at the data, that best supports a two-prong approach with both psychotherapy interventions, a lot of times cognitive behavioral therapy, dialectic behavioral interventions through groups. Those are kind of solid, as well as medications. There was the adolescent depression study that happened a long time ago when we were figuring out if the things we do for parents also help teenagers with depression. And it showed that if you combine these two, you had the greatest outcomes of greater than 70 some percent. And both alone potentially were beneficial, but medication actually alone was more beneficial than therapy on its own. So, kind of keeping that in the back of your head. How I think of therapy is it's a way that helps your brain process, not therapy, medication. How I think of medication, it's a way that helps your brain process. So sometimes when you're feeling overwhelmed, frustrated, not able to manage stuff, that could be an indication that your packets of information going back and forth just might not be at the levels they need to be. When you're not able to figure out what to do, that's telling me that your programming's off. And that's super helpful to have therapy involved, right? Therapy is about building tools, exploring kind of the language in your head and how it affects your mood. And that when your mood's down, your language can be down. But if you shift your language, you can shift your mood, which then even positively reinforces the language in your head. When people start with therapy and they feel overwhelmed or disengaged or they're having a hard time with connection, a lot of times that's telling me that their processing is off and working with a medication could be super beneficial. So your key thing to do with your patients is have close follow up with them and monitor how they're doing, even if they're partnering with another person like a psychologist, to make sure that they continue to progress on kind of the board. Your gold standard interventions are going to be cognitive behavioral therapy, individual therapy, which I lean a little more towards cognitive, especially when there's anxiety components in, and dialectical behavioral therapy, which a lot of times is like an adolescent group skills development where they partner together. Your gold standard medications are going to be your favorite friends, the selective serotonin reuptake inhibitors, SSRIs. And with depression, you have two that are FDA approved, which is fluoxetine, otherwise known as Prozac, and escitalopram, otherwise known as Lexapro. And sertraline, otherwise known as Zoloft, has good child data for diseases like OCD. So we use it kind of as a, if it works for this, it's going to help for this as well.
So, therapy and medication can be helpful. Those sound like topics we should dig into a little further, maybe in our next interview. And so I think pediatricians now can feel like, okay, I know how to assess. I know that I need to be assessing. I know how to validate. I know how to create a safety plan and screen for that suicidality. And then, really, in considering my treatments, understand what is going to work best for a lot of our kids, but also know that our screening tests don't tell us everything. That really we need to be connecting with our patient and asking more questions and really understanding rather than relying on numbers. But sometimes they can be helpful in tracking how well our therapies are working for our patients and if they're maybe getting better or worse or maybe just not improving at all. So it's been great talking to you about kind of this introduction to adolescent mental health, what we've been seeing, what we're concerned about, and how we can best support our patients. So I think hopefully we'll have future conversations to support pediatricians across Iowa and what they're doing and how they're working on. So it's been great talking to you.
It's always a pleasure. I appreciate our time together, Amy.
All right. Well, we'll see you again soon.
Bye, everyone.